We are doing a presentation on Huntington's disease by Tuan Dang, Katie Danko, and Cindy Hang.
What is Huntington's disease? It is a neurodegenerative disorder of the CNS characterized by cognitive and behavioral deficits, as well as distinctive jerky and irregular movement. It is the result of a mutation causing excessive CAG repeats on chromosome 4 and abnormal levels of the protein Huntington. Continuing with, the prevalence of Huntington's disease is 1 in 10,000 to 1 in 20,000 in the Caucasian population. It is an autosomal dominant inheritance pattern caused by at least 36 repeats of the CAG repeat. The more repeats, the more Huntington protein, and the sooner the symptoms present. The signs and symptoms include involuntary choreatic movement. This includes dystonia or torticollis, and it is often the first motor sign. Gradually, the unwanted movement spread from distal to proximal and axial muscles. Talking and swallowing become more difficult as the disease progresses. Patients develop a slowness of movement and difficulty initiating movement. This leads to an ataxic gait and frequent falls. Continuing with, depression is also a frequently occurring psychiatric sign. The patient may experience irritability, anxiety, obsessions, and compulsions, and finally, psychosis. Cognitive decline is another sign of Huntington's disease. Patients lose the ability to make executive decisions in motor or cognitive planning. Additional symptoms include unintended weight loss, sleep and circadian rhythm disturbances, and autonomic nervous system dysfunction. The diagnosis and testing of Huntington's disease is made based on the presence of motor changes with or without cognitive and psychiatric changes, and a parent with Huntington's disease. The current gold standard for pre-manifest diagnosis is DNA determination with at least 36 repeats of CAG on Huntington gene of chromosome 4. EOG recordings are also a valuable objective measurement of the impairment to ocular motility. There is no cure for Huntington's disease. However, the patient's quality of life can be improved by modifying signs and symptoms. Chorea is treated with dopamine receptor blocking drugs such as typical and atypical neuroleptics, including clozapine and olanzapine. Dopamine depleting drugs also work, and they include tetrabenazine. And it is also the first FDA-approved treatment specifically for Huntington's disease symptoms. Depression and aggression are treated with antidepressant drugs, including the following.
Neurological significance. The neuropathology of Huntington's disease is characterized by the atrophy of the frontal lobe and specifically the basal ganglia at the base of the brain, as seen in this image where the basal ganglia are much smaller in individuals with Huntington's disease than a non-diseased individual. Most of the Huntington diseases has focused largely on the impact of the basal ganglia through the progression of the disease. The basal ganglia are composed of the caudate and the putamen, collectively known as the striatum, the globus pallidus, substantia nigra, and the subthalamic nucleus. The basal ganglia is responsible for the motor movements driven by the muscles in the body. Huntington's disease causes atrophy or the death of the neural cells in the striatum first, before spreading to the rest of the basal ganglia and then to the other parts of the brain. There are damages made to both the direct and the indirect pathway of the neural signals between the motor cortex and the basal ganglia. Damages to the direct pathway lead to an understimulation of this pathway. This will result in a slow motor movement typically seen in Huntington's disease. The damages caused by Huntington's disease on the basal ganglia will also cause an overstimulation of the indirect pathway, which will result in the Huntington chorea movement, which is the irregular jerky movements. This slide shows a detailed summary of the direct and the indirect pathway of the nerve signals between the basal ganglia and the motor cortex. Huntington's disease is found to alter the form of Huntington protein, which is found in all cells of the body. Despite this protein being found everywhere in the body, the disease only causes the death of neural cells in the brain. This is primarily due to its interactions with Huntington interactor protein, HIP-1, and Huntington associate protein, HAP-1, which is only present in the brain. The number of CAG repeats in the Huntington gene determines how the Huntington protein interacts with HIP-1 and HAP-1. So, the greater the number of repeats in the gene, the less often the Huntington proteins will bind to HIP-1, and the more often they bind to HAP-1. There are currently several theories to try to explain why Huntington disease specifically target the basal ganglia neurons and how the cell death happens, but more research is needed before we will know for sure.
Ocular complications due to Huntington's disease includes effects on saccades, optokinetic nystagmus, pursuit, fixation, and vergence. The most common visual complaint of patients with Huntington's disease is difficulty reading because they lose their place on the page. Patients frequently drop their eyeglasses because of involuntary chorioathetoid movements. Ocular motor findings such as delayed reflexive saccades and impaired initiation of voluntary guide saccade appear early in the disease and may be detected in the pre-symptomatic patients. At later stages of the disease, patients have difficulty initiating saccades and suppressing reflexive saccades. They exhibit slowing of horizontal and vertical saccades, jerky pursuit, and decreased OKN gain. Convergent insufficiency, blepharospasm, and apraxis of eyelid closure sometimes occur. Little is known about the morphological correlates of oculomotor dysfunction in Huntington's disease. The premotor oculomotor brainstem network is essential for the generation of all types of eye movements necessary for frontal vision and binocularity. In a study with 50 patients with Huntington's disease, 73% of them had unsteady fixation, and about 90% of them have saccades issues, including increased latency and head movement issues. And about 56 to 60% of them had smooth pursuit issues.
Further details in the ocular complications regarding saccades. As mentioned before, the early signs of onset of Huntington's disease are associated with increased horizontal latency and decreased velocity in the saccadic eye movements. In a 2-year longitudinal study that were conducted on patients with early stage of Huntington's disease, which are stage 1 and stage 2, it was found that there is significant worsening of the saccadic latency and mean velocities were detected. In this study, they found that the mean saccadic latency was about an 8% increase per year throughout the studies. A subset of the mean latency in which we are focusing on are large saccadic movement of greater than 26 degrees. And they found that there was an average of about a 13% increase per year. In a few patients throughout the study, they found that they had an overall dropout of large saccadic movement compared to the first measurement 2 years prior. A couple of them had a complete dropout in which they were not able to make this large of a saccades anymore. The mean velocity of saccades found in this study was about a 7% decrease per year in general in individuals with Huntington's disease. There is also an age effect on saccadic velocity found during this longitudinal study as well. The initial saccadic velocity defects tend to be more prominent or significantly worse in younger patients or patients with earlier onset Huntington disease. The mean saccadic velocity also declines with the progression of Huntington disease, which is measured in terms of total functional capacity for all age groups, but notice that there was a significantly slower rate in older patients, which are closer to the normative range. In a study by Beckner et al., Huntington disease patients also showed significant delay in initiation of voluntary saccades, which include anti-saccades and memory-guided saccades, as well as a reduction in the accuracy of their voluntary saccades. This is also found in individuals who are pre-symptomatic Huntington disease gene carriers. The authors in this study found significant correlation between the velocity of the saccades and the number of CAG repeats in the Huntington gene of the individual. They found that the larger the number of CAG repeats had the tendency to have a greater reduction of the velocity of the saccades.
The next ocular complication is optokinetic nystagmus, or OKN. Rotational stimuli produce normal slow phases of nystagmus. However, the fast phase was jerky, slow, or absent in some cases. Referring to the figure on the right, OKN is elicited in patients undergoing constant rotation of 30 degrees per second. It is clear that the slow phases are at a normal velocity, but the fast phases are reduced. The next ocular complication is pursuit movement. Tracking was disrupted by rapid movements of small amplitude, which are thought to be saccades due to their high velocity. In advanced cases, the gain is reduced in both vertical and horizontal planes, necessitating corrective saccades. In addition to the compensatory saccades, a to and fro movement was observed, which is likely due to poor fixation messing up the patient's tracking system. EOG recordings performed in the research by Avanzini et al., 7 out of 11 patients could not track a moving object. This is an EOG recording of a normal subject. Notice the smooth pursuit movement at two different tracking velocities, from the center to the right on the left and the right to the center on the right. Also, in the second figure, notice the refixation saccadic movement. In each record, the upper trace indicates the beginning and end of the spot tracks. Notice the smooth movement of the pursuit movement. Here is another EOG recording of pursuit movement. However, this pursuit movement is in two affected siblings, A and B. Notice the small disruptions in the smooth pursuit movement. The small disruptions are rapid in movement, which suggests saccadic movement. It is evident that the pursuit movement is impaired. There is also defective rapid alternating pursuit movement, as seen on the right.
In terms of fixation issues, early on in the disease, patients have difficulty maintaining fixation, and steady fixation is impaired by unwanted saccades. This is due to a loss of tonic inhibition of the substantia nigra and the frontal lobes on the superior colliculus. Thus, the patient would have difficulty suppressing reflexive saccades to peripheral stimuli. This is an EOG of a patient with Huntington's disease. The figure on the right is recording fixation. Note the several reflective saccades as opposed to a smooth line. Vergence is also affected. Vergence initiation was interrupted by extraneous saccades that moved the line of sight away from the near object. In advanced cases, vergence movements could not be initiated at all.
Up-and-coming management. There are several new options that are coming up in the near future that may provide better therapeutic managements for individuals with Huntington disease. Currently, there are several drugs that were granted orphan drug status by the FDA. The first one is drug candidate HD02. This drug is currently in phase 3 of the clinical trial since 2006. This drug seems to reduce the amount of serum 8-OH2'-DG, which is a chemical that is typically found in high levels in patients with Huntington disease. It also appears to elevate brain levels of creatine. The next drug is drug etho-EPA. This drug is currently in phase 3 of clinical trials in both the United States and in Europe, and it has been granted FDA Fast Track status for a potential treatment for the signs and symptoms of Huntington disease. The last drug is antioxidant coenzyme Q10. This has been granted orphan drug status for the potential treatment of Huntington disease in 2000 and are currently undergoing studies to better evaluate the safety and effectiveness of this drug. Another management would be rapamycin. This drug is currently used to prevent organ transplant rejection in humans. However, it also appears that to slow down the progression of Huntington disease, so studies are currently being conducted to evaluate the potential use of this drug in the treatment of Huntington disease. There has been previous success in the animal studies conducted using this drug, and human studies are currently being planned. The last type of potential treatment will be a type of bile acid called TUDCA. It has been shown to prevent death of brain neurons in mice. However, additional research needs to be done before it will be able to be proceeded for human testing. Overall, new advances are being made, investigated upon, and studied to better improve the lives of those with Huntington's disease, as researchers are learning more and more about the disease itself.
These are our references in case you want to go back and read. Thank you for your time and attention.